This is a magnificent detail of a painting of the Renaissance that allow us to start this short presentation of highlights of the second Clinical Eye Openers webinar dedicated to clinical teratology. Here we see this imaginary creature presented as a monster with multiple nipples or breasts, that is polythelia and polymastia, and presented as a monster or a demonstration of some power over nature, perhaps as a natural or unnatural phenomenon. Over the history of mankind, these sorts of imaginary or even observed occurrences in nature show an admixture of the sharp eyes of artists, poets, painters, sculptors, their synthesis into myths and mythologies that then inspired religions and clergies to perpetuate dogmas that reached then the 1700s, where biological sciences were emerging, that reached the early stages of the development of human genetics and eventually medical genetics, in contrapoint to Aristotle, the father of biology, who held views that were rejected by most of the clergy and geneticists. Aristotle held that all phenomena are natural. There are no such thing like monsters outside of nature. And then eventually reached the level of modern scientific teratology that emerged very late in the 1950s. There is no other medical specialty that emerged so late. And why is that? Because teratology represents a very complex amalgam of notions derived from many basic sciences. And to conclude these general remarks about polymastia polythelia, it serves as an illustration of what is normal. Is it about number, or about structures, or about both? Is it then what is normal symmetric, 2, 4, 6? Or is it possibly that 3 nipples or 5 nipples are considered normal? What is normal for a cat? What's normal for a dog? What is normal for a cow? And then what is normal for a human? And among humans, are individuals with 3 nipples considered to be malformed, or they are just variants? And how variable is the number of nipples and how symmetric in dogs or cats? Is it variable, or is it pretty much fixed? And what is dysmorphic? What's the proportion of individuals with multiple anomalies if they have or don't have polythelia or polymastia? Is polymastia, multiple breasts, the same like multiple nipples? Is dysmorphology here applicable? And that is, are these signals that tell a clinician to look for other anomalies? Are there instances where just plain and simple these are malformed individuals? What is the frequency of polythelia polymastia in a population of mentally subnormal people? These are the sort of very complex questions that are posed for clinical epidemiologists to approach. In the interest of brevity, I must be very brief. These 4 webinars, the present being the second one, will introduce the basis for a better understanding of clinical webinars that are focused on particular categories of syndromes and diagnoses. Here are some shown, and the reasons for choosing these as prototypes are given in the full version of this particular webinar. I suggest that you stop the motion to read screens that you don't have sufficient time to grasp, and do so at any time, or better yet, see the full version of this webinar. Now we like to be practical, so in the first webinar we presented a long video of how to examine an infant for prenatal developmental markers, that is, markers of morphogenesis. This presentation was by Kenneth L. Jones, a distinguished professor of the University of California in San Diego. Here we do that again. This time, Professor Jones would examine an older boy, again within normal range of development, and he will highlight the prenatal developmental signs indicative of normal morphogenesis. In a prospective webinar, Dr. Jones will return with a third video where he's going to demonstrate an examination of a child with signs of teratogenesis due to maternal consumption of alcohol.
And I'm going to do a physical exam, not a complete physical exam, but I'm going to do a physical exam that includes a bunch of things that frequently you're not used to looking at or thinking about when you do it. On the baby's head is stretched around the developing brain as the brain pushes back in a dome-like fashion between about 14 and 18 weeks gestation. So most of brain growth occurs in that dome-like posterior fashion at that time, and the skin is pulled around that. There's no calvarium in between. The skin is pulled around that, and the hair whorl represents the point of maximum stretch on the skin as the brain pushes back, and the skin is stretched. Percentage of people who have 3 posterior parietal hair whorls that are normal, and nobody with no posterior parietal hair whorl is normal in terms of cognitive development. And the obvious reason for that is that there was no growth of the brain posterior at 14 to 18 weeks gestation, and therefore there was no stretch on the skin, and because there was no stretch on the skin as it was pulled around the brain, there is no posterior parietal hair whorl that's formed.
Now that you have seen the video, and I hope you enjoyed it, we can begin again with few comments, and to remind you that the extensive comments in detail are in the full version of this webinar. Here are some fundamental notions that I think you ought to read, and in the interest of brevity, I will move on. Likewise, please read this screen. It is about nomenclature, which is supplemented in our companion website, Pandora Word Box. The central question, contrary to what many medical specialties in other domains emphasize, is not the diagnosis and treatment, it is the prevention of such developmental problems. This screen concerns teratothanasia, and to fully explain it would require more than 5 minutes, which is excessive time for this presentation of highlights. I only wish to call attention that monozygotic twins are teratogenic events, while twinning in general, that is dizygotic, are events due to multiple eggs, that is multiple ovulations that can be induced by the environment. You could call these factors that are environmental. You can call them teratogenic if you like, simply because the risk for anomalies in dizygotic and in monozygotic twins is increased. Next is a short video illustrating a classic medical genetics consultation which you may get as a neonatologist, pediatricians, or if you are a neurologist, it doesn't matter. It is very common for parents to bring a child and ask you a very simple question. Is the child normal? And here is another illustration, a short video stressing the importance of the clinicians confronted with medical genetic, or let's say genetic counseling. The question again is my baby normal? Please watch carefully and consider how would you deal with this question. And so we reach the end of this trailer, and I urge you to see the full version of the webinar, which is much longer. And I remind you then that each webinar has a supplement. In this instance, a very important one, it concerns vascular disruptions, which are causes of malformations that are neither genetic nor external environmental, but rather mechanical. This is a master class by an expert that is worldwide known for his contributions to dysmorphology. Elements of the supplement are included in a short test for those who seek to obtain a certificate of participation.
So it's really a thrill for me to be here as well again and have the opportunity to move forward as far as our collaboration. Most oxygenated blood with the highest perfusion comes from the bottom, and the blood flow goes first to the legs, and the legs develop relatively normally compared to the upper half of the body. And the heart is always not there. That's the name acardia. And the reason is that by the time the blood gets up to the developing heart, which has already started to develop, but by the time it gets up to the developing heart, there's no blood flow up there and no oxygenation. Developing legs clearly are the best developed of all the structures.
And now we have reached the end both of the webinar and the supplement in a shortened format. I invite you to see the full version by registering and enjoying the opportunity to obtain a certificate of participation. And until very soon, please accept my best wishes.